All right, good evening, everyone, or good morning to some. This is another session of Virtual Global Spine Conference. I'd like to welcome Dr. Paul Grabala from University Children's Hospital in Poland. Dr. Grabala is a very well-respected pediatric and adolescent deformity spine surgeon, and we're in for a real treat tonight. He's going to be giving us a lecture on surgical management of spinal deformities in the pediatric population. So it's great having you here, Paul, and looking forward to hearing from you.
Hello, thank you for invitation for me for as a lecturer. I'm pediatric spine surgeon from Poland. I work in Children's Hospital, University Children's Hospital in Poland, in Białystok, and I perform spine surgery for children. So today I would like to present my experience with surgical treatment of spinal deformities in children and adolescents. My disclosures. As you know, spinal deformities can be many etiologies, many classifications for spinal deformities were described. The treatment depends on the curve size, etiology of deformity, progression of scoliosis, child age, patients and family expectations, treatment risk, complications, and possible outcomes. So the main classifications, Lanky classifications, everybody know it, so I didn't want to teach you about it. I think spinal deformities in children and adolescents, we should think about it as many etiologies. For many etiologies, idiopathic scoliosis, congenital scoliosis, neuromuscular scoliosis, and syndromic. I think that is the main for classification for pediatric deformities. In my practice, I think about spinal deformities in children when is in children then aged less than 10 years old, and it is early onset scoliosis, and when deformity are in children more than 10 years old, it is late onset scoliosis. So you can see early onset scoliosis, it is my case, early onset idiopathic scoliosis, a 2 years old child with rapid progression. After conservative treatment, rehabilitation, and casting, the curve progressed, and the main cup angle measured 122 degrees in 30 months old. This is late onset scoliosis, AES, severe scoliosis, 14 years old girl. Of course, treated with rehabilitation, brace, and scoliosis was progressed when we need to operate scoliosis. Indication for surgery is rare. At first, conservative treatment, rehabilitation, physiotherapy, casting, corset can significantly slow down the progression of the curvature and postpone the surgery in young children. I think that delay surgical treatment should be as long as possible to the child's growth potential. Early onset scoliosis need to be treated with surgical treatment, with early surgical intervention when etiology is congenital. Congenital scoliosis should be treated surgically very fast when we see progression. So resection of the bone defect can cure the scoliosis. When and how perform surgery? I think surgical treatment should be as delayed as possible. The main curvature should be above 65 degrees, fighting for preserved spinal growth, truncal height, lung development, and avoiding the thoracic insufficiency syndrome, TAS. So there's no only one, the best surgical technique for early-onset scoliosis. The fusion is terrible for children in age less than 10 years old. Only for congenital scoliosis we can use short fusion with resection. So we have several options with growth-friendly techniques, distraction-based, compression-based techniques, and growth-guided systems. The most common surgical technique is standard growing rods, most common traditional growing rods. New option is MCGRs, magnetically controlled growing rods, and of course vectors. This a child with severe kyphoscoliosis treated with traditional growing rods. Next slide is 2 years old child treated with vector with 10 years of follow-up. You can see a correction of deformity. The other technique is quite different philosophy because we should stop progression in apex and allow to grow the spine in the upper spine and in the lower spine. So the end and the apical vertebra anchored and the spine can slide along the rod. Example of these systems are the Sheila system and model look trolley. So this is my patients. I perform surgical treatment for early onset idiopathic scoliosis at 6 years old child in 2017, and after 5 years of follow-up, there is very good outcomes without revisions and complications. You can see a little pull-out of upper screw, but without PJK, and the child is scheduled for removing Sheila implants and performing spinal fusion. There's clinical pictures before surgical treatment and after 5 years of treatment with Sheila system. The other concept is compression-based system surgery. It is a compressive force on the apex to the convex side of the deformity, and leading to growth inhibition and leading to growth stop on the ipsilateral side. So this technique is vertebral body stapling, VBS, and new technique, vertebral body tethering, VBT. This is my patients treated with VBT. It was surgical treatment in 2019. 13 years old girl with double curve about 50 degrees, perform VBT surgical treatment with mini open approach with double tether. And after 3 years, we have broken tether cord in lumbar spine, but there is a little progression. There is no revision. This girl, you can see very good mobility of spine without any problems.
Paul, can I ask you a question? And I think a lot of the audience would probably have a similar question for you. At what point do you consider bracing a patient versus performing a tethering operation on them? That's the first question. The second question I have for you is about what you do clinically when you have a broken tether, like in this case. Obviously, if they're done growing, my assumption is you would not treat it, but at what point would you intervene?
I performed 3 cases with VBT. Of course, classic indications for surgery was major patients with Sanders classifications 3 or 4. The scoliosis degrees was between 50 degrees to 65, not more. And in my experience, I had 3 patients, and in these 3 patients, I had broken tether, but I didn't perform revision because I observed the patients. There is no progression. The patient is in good condition, so why revision? I think it is. It can be without revision. We can observe, and if curve progress, we can do fusion or tether replacement.
What are your thoughts about these hybrid constructs? I know there's some surgeons who will tether the thoracic, they'll fuse the thoracic spine and then tether the lumbar spine. Do you have any thoughts or opinions on that technique?
I had some friends, surgeons who performs tether. They had many cases and quite lot broken tethers, but not many revisions. Only elite cases need to revision broken tether. Okay.
Yes. Yeah, go ahead. Sorry. Thank you.
Okay. So when we use traditional growing rods during the first surgery, during the initial surgery, we can distract and correct spine and receive correction between 30% to 60%. Next, of course, during the growth of patients, we have to perform lengthenings, the instrumentation. So for standard growing rods, it is between 6 to 12 months. So every 6 months, we have to perform distractions and instrumentation. And the complication rate, it's about 50%. Of course, there are many studies with higher risk of complications. In my experience, when we used standard growing rods, we had pull out of upper screws, infections, but it's still good surgical techniques. VEPT, mainly for patients with TIS, of course, sometimes for early onset scoliosis with congenital spinal deformities. These anchors are placed at the ribs and lower spine, sometimes in pelvis. Lung techniques are performed every 4 to 6 months. And my favorite surgical technique is MCGR. So I will talk about my outcomes and my surgical techniques. So it's magic. Magic rods was invented and introduced in 2009, and of course it is indicated for the surgical treatment of early onset scoliosis with congenital scoliosis, neuromuscular scoliosis, syndromic scoliosis, for patients with many etiologies, but for patients less than 10 years old. Sometimes I use it for older patients when there is a thoracic spinal height less than 22 centimeters. It is technique very similar to standard growing rods, but allow non-invasive distractions without repeating surgeries like in standard growing rod. So the idea of this technique was to reduce complications. Of course, there are many studies, many surgeries, many opinions about these techniques. All techniques have complications. In MCGRs, commonly, of course, is associated with metallosis and maybe implant failure complications. So indications for surgical treatment is similar, like in standard growing rods. Risk of the procedure is similar. The surgical technique was described in our 2 papers. First, it was less invasive approach to early scoliosis based on treatment 2 years old child as case report and surgical technique video demonstration in operative neurosurgery. I think there is very interesting video. So this is my first case, MCGRs. I performed surgery in 2017. So it was AIS, early onset idiopathic scoliosis, before surgical treatment. Less invasive approach, only 2 incisions on the upper spine and on the lower spine. Pedicle screw placement via freehand techniques, and this after surgical treatment after initial surgery. You can see on the left X-ray the magic rods are very straight, very flat. It was my first case, so I didn't know how to bend very good rods for restoration of sagittal balance. I will show you on the next slides my better techniques for bending rods and for restoration thoracic kyphosis and sagittal balance. So you can see this gear after 5 years treatment, and after removing first magic rods and replacement for new magics, you can see better restoration of thoracic kyphosis and lumbar lordosis. Of course, there is very, very good outcomes with correction and balance and full activity.
Paul, there's a question in the chat box from Dr. Mike Selby. He's also a pediatric deformity surgeon in Australia, and he asked if you take your growth rods out as recommended in low demand kids after a few years.
Can you repeat?
Dr. Selby asked if you take your growth rods out as recommended in low demand kids after a few years.
I try to use for my patients MCGRs rods, but sometimes when child is young, when the weight is not enough for magic rods and curve progress, I use standard growing rods.
Okay.
The next case is 4-year-old girl with syndromic kyphoscoliosis and MCGRs placed in 2019. This after surgical treatment and good sagittal balance, good correction. And after 1 month of initial surgery, the child has had deep infection and needs revision, but without implant replacement. Only debridement, surgical debridement, and cleaning, antibiotics, and everything was good. After 3 years lengthenings, you can see broken rod. So second revision and replacement to magic rods. And next it is 1 year after the second revision, 8-year-old girl, 4 years of follow-up after initial surgery. This is 8-year-old girl with early onset idiopathic scoliosis. I performed surgical treatment with MCGRs 4 years ago. This before initial surgery, after MCGR placement, after distraction, and after conversion to posterior spinal fusion. And during revision surgery, during conversion to posterior spinal fusion, on the right side, there were autofusion and metallosis. You can see near the cup bone and fusion. So I perform multi-level osteotomies of ribs and ponte osteotomies on apex to perform correction for this girl.
Paul, when you say that you do rib osteotomies, are you basically just disarticulating them at the costotransverse joint, or are you also going a bit more anterior and doing a disarticulation of the costovertebral joint as well?
No, I try to do all from posterior, and when I perform a rib osteotomy, I resect about 2 centimeters of ribs on the apex on the right side.
Okay.
This is next case, 4-year-old girl, at the EDS syndrome, initial surgery with MCGR in 2018. And after distraction course, without complications, 3.5 years follow up, MCGR replacement for new magic rods. Next child, 4-year-old girl with early onset idiopathic scoliosis. It was my second case in my career. After magic placement, there was complication 3 weeks after initial surgery, pull out of upper screw. So I replaced screw for I put 6.5 millimeter screw on the thoracic spine and one hook. And after this surgery, there were no other complications. After 4 years of follow-up, MCGR replacement in 2022 for new rods. And this is this child. So you can see there is mobility, relaxed, and very good outcomes. This is a very interesting case. 16 years old boy, syndromic scoliosis, Chiari, Syrinx, Teter cord, and Costello syndrome, and of course severe scoliosis. After Chiari decompression, I put MCGRs in 2020. And after distraction, after 3 years of follow-up, I converted MCGRs to posterior spinal fusion. You can see outcomes before surgery and after conversion to posterior spinal fusion.
Paul, this is probably a good time to ask a question. Dr. Baj had placed in the chat box, if you're ever seeing autofusion with use of these magnetically controlled growth rods, which would subsequently make a more definitive correction later on more challenging.
Yes, most of, maybe not most, but many patients had autofusion during MCGR's treatment course. So correction is hard because spine is fused and very, very stiff.
Do you see that it's predominantly a posterior autofusion, or are you ever seeing them fuse
Posterior.
across the space? It was all posterior.
Posterior, yeah. And this is very stiff scoliosis, 8 years old girl, syndromic scoliosis. So I couldn't put 2 MCGRs, so I use only one. And at 2 years of follow-up, there is no complications. Very interesting case with congenital scoliosis. The child has multi-level blocked vertebra, 2 hemivertebra, and treated with casting and brace. And after this treatment, the main curve was 120 degrees. So I ordered hollow gravity traction during 3 months. And next Next, after hair retraction, PVCR T9 and T11, and one side MCGR. And this is clinical pictures before starting halo traction and at 1.5 years of follow-up with no complications. This is main curve before surgery and short fusion after resection of two hemivertebrae and MCGR for destruction of one side. So, in my opinion, benefits in using MCGR is less invasive surgical treatment, only to minimal incisions. We can avoid many surgeries, many multi-day stays in hospital every 6 months, anesthesia and infections. I think there is less complications than traditional growing rods in my experience. My outcomes with 5 years of follow-up, I got 101 MCGRs, 52 patients, and all complications is one deep infection, one superficial wound infection, 5 broken rods, 8 implant failure, 2 pull-out upper screws, 2 PJK, 6 cases out of fusion, and revision 10 patients, about 20%. So surgical treatment with MCGRs has a risk of complications, of course, and revision procedures about 20%, especially in syndromic and neuromuscular scoliosis. This risk of complications is higher. My surgical technique is less invasive approach, as described in our papers. I used pedicle screws via freehand technique, always using 4 screw on the upper spine and 4 screw on the lower spine. Sometimes I use TP hooks on the top as prevention of PJK and pull out of upper screws. And for children between 2 and to 6 years old, I use screw on the upper spine 5.5 millimeters and 5.5 or 6.0 on the lower spine. For older children between 6 to 11 years old, I used a larger screw for better stabilization on the upper spine, 5.5 or 6.0 millimeters, and 6.0 and 6.5 millimeters on the lower spine.
Well, I don't think your slides are advancing. It looks like they've been stuck on the same slide for a little while with the young girl with the halo traction.
Halo traction?
Yeah, is that the slide that you're seeing too?
No.
Yeah, it looks like the slides are stuck. Ali, do you agree, or is this is not just my computer?
Yeah, maybe a good idea to kind of just reload the presentation. Yeah, I think it is stuck.
Maybe you want to stop sharing briefly and then reshare it again, the screen.
Okay.
I think you should try to stop sharing the screen and then you can reload the PowerPoint and then reshare it again, because we're not seeing any of the slides advance.
What about now?
Now it looks like, yes, we can see that.
Okay, so always two rods in configuration standard and offset, and special bending rods for prediction of PJK and pull out of upper screws. I order corset or cast for first 3 months after surgery, and I use lengthenings every 2 months, 2 or 2.5 millimeters every 2 months, and I perform X-ray every 6 months. So now I will talk about congenital scoliosis. Congenital scoliosis are most frequent caused by hemivertebra, and can usually provide serious consequences in spinal growth. So without any treatment, about 80%, 85% of the patients will have progressing spinal curves more than 40 degrees. So hemivertebrectomy via posterior approach and fusion is effective if performed yearly. There are many surgical techniques for hemivertebrectomy, from anterior approach, from posterior or combined approach, axial osteotomy or radical vertebrectomy. I use transpedicular axial osteotomy and radical vertebrectomy, and I think they are the best techniques for surgical treatment of congenital scoliosis in children. So steps are small incision, pedicle screw placement only for level 2 levels or 3 levels. It depends on deformity. If it is thoracic spine, rib osteotomy, about 2 centimeters enough in children. Next, vertebral body resection, disc resection, and correction via compression, screw and rods. This is my surgery. So screw placement, laminectomy. I like to use diamond drill for resection of vertebral body. After decompression, after vertebral body resection, compression on the rod, and this film.
So where are you getting your arthrodesis in this case? Are you just doing a hemilaminectomy and then taking the pedicle down on one side?
I mostly I use full laminectomy and fusion both sides.
But where is the surface area that you're putting your graft down if you've done a full laminectomy? Are you just putting it down across the surface area of the facet joints, or are you decorticating the costotransverse joints and trying to get a fusion across there as well?
Yeah. I think after removing after laminectomy, after removing vertebral body, after compression, I try to put bone graft decortication for fusion in stabilization levels.
Will you ever use like a fibular strut graft, across the levels of the 3-column osteotomy? I typically will do something like that, or I'll use one of these long absorbable bag of bones essentially across the 3-column defect, or I'll tether a fibular strut graft to my rod. Do you do anything like that too, or do you feel that it's not necessary to go to that
In
length?
children, it's not necessary. So this is a 5-year-old boy, Chiari, spinal cord tethered, syrinx, congenital scoliosis with dislocation, spinal cord compression. You can see CT scan, X-ray before surgery and after resection, and short fusion. Very good outcome. This is an example of 3-year-old boy, congenital scoliosis, hemivertebrectomy from posterior L1, L2 with short fusion. It's before and after surgery. And I perform CT scan after 3 years from initial surgery. You can see good fusion. So for good correction, we can have to put screw in very good position. So adequate pedicle screw placement for pediatric patients is maybe a little part of spinal deformity surgery, but is very important because we can have success or failure. Of course, biomechanical screw performance, less loss of correction at 2 years than hooks. And we can have very good stability, improved coronal sagittal notation correction, better than hooks or other techniques. So I try to show you techniques for AIS correction. We can think about structures at risk, but everybody know it. Pedicle morphology classification is very important in children because mostly on the apex there are dysplastic cortical channel or absent pedicle channel. There is problem with pedicle screw placement. So we can put screw extrapedicular or use other technique when we have navigation. It can be very helpful for safety pedicle screw placement. Our 2 papers about screw placement and influence of increasing pedicle screw diameter for vertebral body and pedicles. In this study, we compare pedicle screw diameter in MRI before surgery, so it is on the left side, and after surgery, after screw placement on CT scan. We can see that pedicle screw expand pedicle without bridges. So in this paper, we can see that if we use larger screw, the pedicle diameter is expanding via screw. So in conclusions, our study confirms that a wide range of expansions of the vertebral pedicle is possible during screw insertion, including up to 78%. So I think it is very good conclusion, because we can use larger screw in correction of scoliosis, and we can receive better correction, better biomechanics, and better restoration of scoliosis, of spinal balance. Techniques of screw placement, so everybody know it, so I didn't want to talk about it.
You know, it may be worth going over in just a bit of detail what your steps are for dilating the pedicle. Obviously, you'll start with a pilot hole. Do you do progressive tapping at that point, or do you just go straight to the screw?
I sometimes typing screw, but mostly I perform a canal for screw with Lenki, and next put screw without typing.
So
Sometimes I use drill for pedicle canal.
okay, and you don't routinely use navigation for these?
No, no.
You freehand everything?
Yes. Sometimes use power device for.
So are you measuring all of your screws before the operation?
Yes,
The
yes.
CAT scan, MRI, and okay.
No. For all patients, I use MRI before surgical treatment, but I measure screw after performing canal for screw. I use probe, and I try to measure with probe how long should be the screw. So I don't use CT or MRI for measure pedicles or screw diameter.
So your average width is about a 6.0, irrespective of the diameter of the pedicle. Is that correct?
Mostly I use 6.5 screw on the lumbar spine and 6.0 in thoracic spine for all children. Okay, deformity correction. So I will try to talk about my techniques for deformity correction. I use posterior techniques, and my goal for this treatment is at first aggressive facet joint resection, ligament removal, ligament of flavum resection, and multi-level Ponti osteotomy. Sometimes I use intraoperative traction, but mostly I use facetectomy for visualization landmarks for starting points and for mobilize the spine. I perform freehand technique for screw placement, ligament removing, Ponti osteotomy for correction kyphosis, lordosis, scoliosis. I remove inferior and superior facet with Kerrison. Sometimes I use ball scalpel. And this is examples for multi-level Ponti osteotomies. How we can mobilize the spine with severe scoliosis. This 19 years old boy, hyperkyphosis, back pain, 6-level Ponte osteotomy, 2 cobalt chromium, 6.0 rods, and good restoration of sagittal balance and deformity correction. Multi-level Ponte osteotomy is very good correction without anterior releases. So I think Ponte osteotomy is very powerful techniques for mobilize all AAS deformity, maybe not congenital, but AAS rigid severe deformities base for surgical treatment. 16 years old girl, AS, multi-level Ponte osteotomies and correction with 2 cobalt chromium rods, 6.0. Is 18 years old boy, AS, similar correction. So correction techniques which I use: distraction, compression, of course, distraction, concavity, decreased scoliosis, compression, convexity, decreased scoliosis, compression for LFR leveling, rod rotation, inside contouring, coronal sagittal translation, cantilever correction, sometimes segmental derotation, on block derotation, differential contouring rods. On block derotation, mostly I use freehand screw placement and I use all multi-axial screws. Only on apex I use uniaxial screws on convexity. I perform multi-level Ponte osteotomies. Main correction using differential contouring rod. I used always 6.0 cobalt chromium rods. I use translation, derodation, compression, distraction, and sometimes in situ bending and sometimes segmented derotation. This is animation of technique which I mostly use.
Paul, what's your order for rod insertion when you have a double major curve?
It depends of size of curvature, because when it's severe scoliosis, sometimes I use temporary rod, and with this temporary rod, I try to correct one curve on, for example, on the left side, for better and easier placement rod on the other side. So after using temporary rods and correction of, for example, lumbar curve, I put rod on the right side, remove rod on the left side, temporary rod on the left side, and put long rod on the left side, and finally correct on the both rods. This correction by translation, very, very good, very powerful when we use cobalt chromium rods. And of course, we have to mobilize spine with multi-level Ponte osteotomies. On block derotation, we can use segmental derotation. Okay. And this is some examples. 17 years old girl, AIS, severe AIS. I use 6.5 screw on the lumbar spine and 6.0 screw on the thoracic spine, and double cobalt chromium rods with multi-level Ponti osteotomies. And this is effect after surgery. The next 17 years old girl, severe AS, similar technique, 6.5 screw on the lumbar spine, 6.0 screw on the thoracic spine, cobalt chromium rod 6.0, and multi-level Ponte osteotomies. This is the same surgical techniques. And severe scoliosis. I would like to talk about my technique which I use to correct severe scoliosis. As we know, severe scoliosis are spine deformities with a cup angle more than 90 degrees, and surgical treatment can be very challenging and difficult for this case, with higher risk of complications. We want to avoid compression of a spinal cord, neurological deficits, and other complications. We have some treatment options for severe scoliosis: halo gravity traction, halo femoral traction, halo pelvic traction, or intraoperative traction. Other techniques: internal distraction using temporary internal distraction rods, anterior posterior release, thoracoplasty, PCO, apical spine resection, and combine of several techniques. Temporal internal distraction rods was introduced by Buchowski in 2006. And there were some modifications performed by Toll and Skaggs. Buchowski and Skaggs techniques, it was technique with white wall lamp posterior spinal exposure, multi-level osteotomies, and gradual distraction between upper fixation using rib hoops and pedicle screw in the lumbar spine. Distraction, of course, under neuromonitoring, one-stage surgery or staged surgery, final stage performed between 4 to 10 days after temporal rods inserted. So this is X-ray from Skaggs books and Skaggs techniques. You can see rods for temporal distraction and final outcomes. This is the paper about neuromonitoring changes during using temporary internal distraction rods. My technique was described in 2020 with we described our modification with Ilka Helenius. Less invasive approach with Ponte osteotomies following segmental screw instrumentation and staged surgery. In first stage, I perform less invasive temporary internal distraction via 2 short incisions, similar to the standard growing rods, over the proximal thoracic and lower lumbar spinal regions. Pedicle screw placement with posterior column osteotomies I typically perform at levels between T2, T6 and between T12 and L4. And rods were inserted subcutaneously connected to the pedicle screws with a safe rotation followed by optimal internal destruction of the spine with neuromuscular checking, and final blocking of the internal temporal rods. And this is my techniques, like growing rods. And this is X-ray after insertion temporal internal destruction rods. The second stage I perform 2 to 6 weeks after the first operation, and during the second stage I perform a ponte osteotomies on the apex of the curvature and segmented bilateral pedicle screw placement and final correction using 2 cobalt chromium rods 6.0. This is example. Severe scoliosis, very stiff. After temporal internal destruction, you can see on the right X-ray. And after second stage, this is on the right side here. This is this girl at 2 years of follow-up. Before surgical treatment, temporal internal destruction, and final surgery. Next case with temporal internal destruction techniques. 17 years old girl. After first stage, destruction, and after final stage. Other technique with MCGRs as temporal internal destruction. There are several papers about these techniques. It is similar idea to Buchowski and Skak's techniques, similar wide open approach and multi-level ponte osteotomies. Destruction are performed 1 to 3 millimeters per day for a mean total 2 weeks, or 5 millimeters every 5-7 days. And after receiving good destruction, final fusion. That is cases for papers from PubMed. And my experience with temporal internal destruction with MCGRs is 2 wide open approaches and 2 surgeries, difficulties in adequate bending and rods placement, not for every severe scoliosis case, and not good for kyphoscoliosis, and problems in destruction course, never destructed more than 2.5 centimeters. This my case with MCGRs as temporal internal destruction. First surgery, first stage, magic rods placement, and after destruction, removing MCGR and final fusion. And this girl at 2 years of follow-up, before surgery and after 2 years of follow-up. We published our outcomes with these techniques and compared to hologravity traction, and there are no benefits in using MCGR as temporal internal destruction in comparison to hologravity traction. Other techniques in literature, you can see similar outcomes with good correction, about 50% to 70%. And combination of several techniques, hologravity traction, posterior ribs osteotomies, this very severe scoliosis, 16 years old girl, after 6 weeks halo gravity traction, multi-level ponte osteotomies, and 5 ribs osteotomies, and this is final outcomes on right X-rays. This is this girl before and after treatment. Next, 14 years old girl, severe AS, about 150 degrees. Stage surgery with temporal internal destruction, rods, and final outcomes. 13 years old girl, severe AS, with temporal internal destruction, rods techniques, and of course final outcomes. And summary: temporal internal destruction rods provide deformity correction about 55%, with good outcomes, clinical and health-related quality of life. Planned surgical treatment can achieve a very significant deformity correction with a minimal risk of complication, and surgical treatment has a superior impact on quality of life of patients with several spinal deformities. And several cases with congenital scoliosis. Several congenital scoliosis in adolescents, when it progressed, should be treated with trichomostotomies. And there is 13 years old boy, congenital scoliosis, stiff deformity. I performed asymmetric PSO and spinal fusion from posterior approach. 16 years boy, congenital scoliosis, vertebral column resection and fusion from posterior. And congenital kyphoscoliosis with spinal cord compression after resection T10. There's the second day after surgery. And this is before surgery, clinical picture, and after resection with 3-rod techniques with good spinal, sagittal spinal restoration. Thank you for attention. Sorry for my language.
Oh, thank you. That was absolutely fantastic. That was a real tour de force. You covered a lot in just over an hour. I know Dr. Baj has a real passion for pediatric deformity surgery too, as I do. But this was a real treat for us. So really appreciate you taking the time out of your busy schedule and chopping some time out of your sleep tonight. So thank you. Ali, what do you have on tap for next week?
Yeah, thank you. Thanks, Pavel. That was absolutely great. And thank you to Dr. Golgano for inviting you. This was excellent. Next week, we're going to take things into a little bit different direction. We're going to show some of these both less invasive and complex cases, but using, on the opposite spectrum. Instead of freehand, we're going to do some navigation and robotics and technology, and really focusing on what the challenges are and what the opportunities, as opposed to just saying how great the nav is or how great a robot is. We're actually going to highlight what the challenges are, what the complications are, and what we think the future holds for these enabling technologies. So that's next Thursday.
Awesome. All right, all have a great night. Paul, go get some sleep before your case tomorrow.
Thank you very much.
Thanks, Pavel.
Thank
Take
you
care,
all.
guys. Take care, everyone.